Good day, good afternoon. I'd like to start a live session for focus on the CTO region. So the panelists, please come to the stage. So I'm Dr. Otsuji from Japan. Unfortunately, Dr. Scott Harding had to leave here because of the flight schedule. So we have a very excellent panelist, Yoon, Robert Thomas, Sung-ha, Shozo Ishihara, Chang, Jun-Hyok, Gyung-Min, Jun-Soo. Welcome. Go to the Severance Hospital, Big A.
Okay. Can you hear me?
Yes, I can hear your voice, but
Okay.
not change the screen yet.
Yeah. Please change the screen.
Okay, I can
Okay.
see your face clearly.
Okay. Yeah, good afternoon, everyone. So it's great honor to perform the live demonstration in front of the Otsuji sensei, and it's a really appreciate SJ Bot. So the today's case is ICA CTO case. Okay, so let me introduce our team. Is Professor Lee is the second operator, and then Seung-Jun Lee, Professor Lee, and then the different Lee is my fellow is Yang Lee is a third operator. Okay, so SA Lee could you show us the today's case?
Yes, the 67 years male patient presented with worsening dyspnea and chest discomfort on exercise. Recently, he suffered stroke and he underwent a stent insertion in his carotid artery, and he had hypertension and diabetes at baseline. Next slide. In ECG, there was no definite ST segment change, and the echocardiography showed normal cardiac function. However, in the SPECT MIB scan, there was a reversible defect at the basal inferior wall, indicating the arterial ischemia. Next slide. In the angiogram, the circumflex showed no significant stenosis. However, at the LAD, there was diffuse moderate stenosis at mid-LAD level. Next slide. However, in the areocranial view, there is multiple collaterals from looks like the septal to PD, and next slide. And there also looks epicardial collateral from the OM, proper to the PL branch. And as you can see there, the ICA ostium shows tapered tip shape, the CTO region, and there looks severe calcification. Next. So reviewing the angiogram, there looks like the ICA CTO, it looks like more than 2 centimeters, and the calcification is also noted with tapered tip morphology. So the JCTO score is 2, and next slide. So we underwent the CT angiogram according to our CT-CTO protocol. Next slide. So as you can see there is the severe calcification throughout the CTO segment, and the lesion length was 28 millimeter. And the calcium is, although it is not full shape, but very dense calcification is at the ICA ostium, and the tapered shape corresponds to the angiogram. So this is today's case.
Okay, Professor Lee. So this is our case. So as you can see, is a good thing is the CTO proximal tip is tapered. A bad thing is the whole calcification was noted on the angiogram and then the CT scan, and also the on the angiogram the vessel size is very small. Okay, so related this case, is there some comment or questions?
So do you have simultaneous angiography today?
Okay. So after
You can see the vessel length well.
Okay. So today's angiogram, please. 오늘 엔지오 찍은 거 요거 지금 돌아가는 거 보여주세요. 예. This is the angiogram. So we prepared a bifemoral system. It's both 7-branch guiding catheter. So from this area of caudal and area of view, so some calcification and also some collateral flow was mixed. Next one. This is the cranial view. So the previous Professor Lee mentioned is some septal channel was noted, but the predominant was the flow was the epicardial collateral flows, the circumproper. Okay, this is the today's simultaneous angiogram.
Okay.
Yeah.
So the very diffuse calcified stenosis on the distal end is not clear. But small, very small.
Yeah, right.
So I'd like to ask the. So Dr. Baga, you start the undergrad.
Yeah. Look, I think when I look at the angio we're looking at, there isn't really an obvious septal collateral. I mean, they may be there below the resolution of the angio, and you could surf with a Sion, 3-wire. But I think the nice thing about the right is it's tapered, and there's a segment that you can probably get a nicely polymer jacketed wire and just take a caravel and just play with it, and I think it will eventually find the microchannel and hopefully go through. There's a nice landing zone which you see on the contralateral injection, and I think it's a safe, should be a safe, I hope, straightforward procedure.
Which wire? The polymer jacket?
Yeah, I'll just use an just go with my normal Sion wire, and then I'll just take probably an XTR or a Gaia third maybe. I like to feel my lesions. It gives me an idea, and some of them I feel that if you're making progress with a gentle wire, it will just run. And then obviously if you've got, because it is calcified, if you're finding sort of brick walls, then I just wire escalate and just go with the ultimate.
So first try to microchannel tracking.
Yeah.
In this case, okay. So BK.
Yeah. So
what's your opinion? Yeah.
Okay.
So
what actually, definitely this case is we can see so as previous mentioned, the calcification is sometimes a very good, very bad problems, but sometimes we can use the calcification route without contrast. So on the aerial cranial view is we can see some root of the R-shaped vessel path. However, also is some problematic is a very weak guiding support. So this is we had some take many times to engage it properly. So and also we already started this case, and also this is the live case. Anyways, if we failed antegrade, we should do some retrograde something. So before. So definitely in the real world case, I will start with the antegrade case. But before that, so I just prepare of the retrograde.
I mean, I'd think about putting an anchor wire and a balloon in the conus. And then bring that guide straight in.
Right. So definitely agree. So many sometimes we omitted some balloon anchoring. However, balloon anchoring is in addition to the strong backup. So and also the positioning of antegrade wiring puncturing portion is also would be good with the good backup. So if we do the antegrade CTO, so I definitely in this case is a conus anchoring is definitely needed. So okay.
How does it work now?
Any other comments from panel members at this stage? You? Anyone?
I prefer to antegrade approach. Field first choice wire field XTR or field XTA supported by microcassette. So that, and then if needed, backup strong backup is anchor ballooning. You recommend the same too.
Okay,
Okay.
let me show also, today's preparation. So as I previously told you, I used the bifemoral system. Next slide, next image. Yeah, initially put the wire in the corners, next one. And then we just put in the middle of or in the start of the RCA CTO, next one, next one. So as I previously told you, I just want to preparing the retrograde. So as you can see on the areocranial view, is first septal is quite big. However, is some stenosis was noted, and also this patient of LAD has a very diffused region. So if we put some retrograde, is if patient chest pain occurred, so we will prepare also the LAD intervention. However, anyway, the patient has no symptoms, so I firstly use the surfing with the first septal wire, first septal branch. Next one. Next one. Yeah, so this is the shown with the very big bending. Next one. Like this, not easy. Yeah. But some negotiation. The next one.
I think there is calcium.
Right.
Osteum.
Right.
So maybe the difficult wiring and
But
also the microcatheter passage.
yeah. So luckily, the wire passed. Next one. So this is the Corsair Pro XS. Down. Next one. And this is the tip injection. So we can see of the some root of the epicardial way, also some septal way. However, so we just called some kind of various even with a very good supply from the septal branch. However, so many septal branches is not so good. It's really one thing good is sometimes better, even with 10 septal collateral. Next one. But so we this is the areocranial view. But there is some septal or some way to the RCA, also we can see. However, in the connection point is tortuosity is very, very severe. Next one. So I changed the SWO 3 times. This is the next one. So we use the many collateral of the septal. So I try and the next one, next one, and TB injection again. Next one. Yeah, but this is the no direct connection was noted on the this big septal branch. Next one. Next one. Next one. So next one. Next one. So I tried everything, every septal branch is with, and this is also we can see of the some connection. However, in the middle of connection is there was a very severe banded portion. Is SWO wires did not overcome. Next one. Next one. Next one. Next one. Next one. Next one. So and also I tried the other branch. Next one. Next one. Next one. Next one. Next. 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 Yeah. So the distal septal is also the is surfing into the distal septal. Next one. However, the wire was passed. However, at the end of the this branch is there was no connection. Next one. Next one. Next one. Next one. So at this time, I should decide anyway. So I will firstly procedure using the antigrade. However, anyway, the retrograde some way we need it. So the next one. And also I had some time before the broadcasting. Next one. Yeah, this is the epicardial collateral from the proper to peer. So the Otsuji sensei, so what do you think? This kind of some torture was noted. However, the length was not so long. Right, next one.
Maybe.
Yeah. So on the area view, next one. Yeah. This is the from the tip injection, even with some tortuosity, but I think the collateral diameters is so good. So the if I fail the antigrade CTO, so maybe I think this epicardial route could be useful. What do you think? What do you think?
I don't want to do this procedure.
Me too.
I think you're very brave. Very brave.
Okay.
Nice to see.
Yeah, I just find some way, so I did not wiring. Okay, next one. So and then
Maybe
I
you
will-
you can find some peer channel.
I think the septal did connect, but I would use a slightly stronger, more slippery wire like a Sion Black.
Right.
If I had to do, I'd go back to the septal and I'd just maybe use the Sion Black because I think it will get through.
Okay.
In such cases, sometimes the peer channel and even into small but straight peer channel connect to the peer. So the final step, you check the peer channel.
Okay. So this is the anyway some preparation of the retrograde. So the anyway I should do the antigrade CTO in live demonstration. So the this is the balloon anchoring with the corners, and then the I started wiring with XTA. XTA.
Okay.
So and also the some classification, this marking was noted in both. So our system is biplane coronary angiogram. Next one. So however,
What microcatheter? Sorry, I didn't hear.
Corsair Pro.
Oh yeah, okay.
Yeah, Corsair Pro. Yes, but this is the XTA, but some bended portion and also the thick calcification is XTA did not overcome. So I should change it. So what do you think? So I firstly, so from the CT scan, the calcification to very much, and also, however, even with the CT scan, CTO length is greater than 20 millimeters, but the angiogram is some connected portions I can see. So in that kind of region characteristics, I prefer the Gaia series. What do you think?
Yeah, it's a right way, I think.
Right. So so I did not much time. So immediately change it with Gaia next one. Next one.
Yeah, that's right.
Yeah. So
I choose Gaia next one. Yeah, as you do.
So some wire tip is I can easily negotiate and navigate. Next.
But
And then
is your
a little
anchor?
bit
Is the
of the
anchor
band stuff.
anchor balloon isn't inflated, right? It's not inflated. You're gonna.
Sure. No. This is the image retrograde injection. So during the procedures, the inflated
Okay,
anchor balloon.
yeah.
just depleted for this angiogram, and then check with the retrograde system, some classification and also some contrast marking is some kind of confusion, but especially on the aerial image is even with the classification on the right. However, some tip portions is very vague, and however, on the area view is the wire course was good. Next one. So I advanced again. And then the wire tip, so a little bit advanced. However, at the end of the tip is some bended.
Branch or
partition,
plaque? In the plaque
right?
or branch?
Next one. But from the aerial view, the wire way is very good. And also the previous mentioned is on the aerial view is the wire portion a little bit left. However, on the aerial image is the wire and then the course was good. So I advanced wire a little bit more. Next one. And some bended portion, but smoothly slided into the right way.
Well
Next
done.
one. Next one. And then I checked the retrograde. Has the wire very luckily is PL wiring was successful.
You choose the right guide wire
Oh, okay. Right.
based on the CT findings and the angiographic sign. So why didn't you do first this procedure?
Okay, next one.
Because the retrograde approach is very difficult. Seems to be very difficult. So
Right. So definitely because of the live demonstration, so I want to perfect success for.
but you
Sensei
did
and
perfect.
everyone.
You did perfectly.
Next. And then with the anchor balloonings, the ballooning is 1.5. Next one. And then I check the IBUS. Professor Lee, could you show me the IBUS findings? IBUS 보여주십시오. So from the angiograms, as we expected, is a very diffuse region. However, the vessel size was not so small. This is the just before the PL-PD bifurcation. Okay.
So this is the distal portion. So as you can see, the vessel size is about 3 meter. However, the lumen size is less than 1, so indicating very large plaque burden. However, the lumen is entirely located in the true lumen, indicating interluminal wiring. And you can see the very diffuse calcified plaques throughout the RCA CTO segment, indicating very long region. There is a severe calcification around that 180 to 270 degree, very severe calcification, and vessel is going in rise, but the wire entirely passed through the intraluminal wiring. So lumen here is very tight region, so it's dark, but anyway, the calcium is not full moon. The vessel is being enlarged around that here. So anyway, the distal reference vessel size was 3 millimeter, and proximal vessel size is about 4 millimeter.
Okay, so and also this proximal arch-shaped vessel size was very big. Next one, and based on this view, using the Sasuke, the wiring to PL was angiogram 보여주십시오. 엔지오 보여주세요. Okay. Next one. Okay. Yeah. Next one. And then we took the angiogram is antegradally. So the proximal portion is anyway it's very diffuse and tight region, and also we did not know some severity of the PDPA bifurcation. However, on the IBUS findings is anyway the whole region is with so many plaques. Next one, so I increase the balloon size 2.0. Next one, next one, next one, next one, and then and also this is the angiogram after 2.0 ballooning. Okay, this is the end of the procedure.
Okay. So we'll discuss how to implant the stent, which part from the which part.
Balloon.
Yeah. So, Vijay, you want to
Okay.
put the stent just
Yeah.
the CTO region or the
Right. So in this case, anyway, I put the stent in the proximally first with a long stent, and also the distal portions based on the IVUS findings. If possible, I put the did not one more stent. I just TB of the distal
okay.
RCA.
so you expected better dilation distal the stenting.
Right.
Yeah. Okay. So.
3.0에 3파 하나 준비요.
So I think in my practice, if I open a CTO and I use a small long balloon and it doesn't quite expand, I go straight for rotablation, because one of the things that have happened is that I keep trying with the balloons. You cause like too much dissection, and then you can't use rotablation, or at least it's prohibited. So I'm quick to switch to rotablation
But
if need be.
this case also has a lot of plaque.
Yes,
So
yeah.
some distal flow disturbance after rotablation.
Yeah, potentially, but I don't think you need rotablation here. But in the last case, where you've got 10-year-old CTO, if you don't do some form of debulking, then you just get a restenosis. Remember, binary restenosis rate in CTO, if you don't prepare the lesion, is very high. It's like 60%. So I also don't do very much antegrade injections after.
Yes.
Because that can make things worse as well.
Yes, the Iverson is enough.
Yeah.
So because of time limitation, anyway, I will put the proximal stent.
Okay.
Is I think maybe the based on the IVUS findings, so is a 3.5 ballooning will be needed. However, the considering the of distal vessel discrepancy, so I put the 3.0 long stent.
Okay.
Right.
Okay. Big thank you. So let's move to the lecture. Dr. Habara from Toyohashi Heart Center.
Thank you, Otsuji Sensei. So, and I'm glad to have a chance to talk in complex CTO, complex PCI. So my title is "When to Go Retrograde: Insight from Pooled Analysis of the CTO PCI." So this is about the CTO PCI success rate. As mid-2000, that was only 50 to 70% of the cases. But nowadays, that was rise to 85 to 90%. So that is depend on the evolution of the CTO PCI. First is refinement of the equipment. So of course, guide wire. That is previously we have only Miracle series or Confianza. That is recently XT series and the Gaia series, and microcatheter. That is we have so many Corsair or Fine Cross in Japan that we can use as a Jizai or something. And the development of the novel technique of the parallel wire technique, and I was guided while rewiring, and the ADR, and also retrograde approach. And the understanding of the CTO pathology and the mechanism of the guide wire manipulation within CTO is also important. That is also guide wire deflection or whip motion or something. And so this is a summary of the recent registry data. So Retrograde Summit and also expert registry, that is also depend in the Japanese physicians. So APCTO, that is also Asian CTO operators, so experts data. And research and progress, that is so Europe and the US data. And so all of those procedure success is around more than 85% of the cases. So that is so great. And so within them, so retrograde approach is also around 20 to 30, and so APCT is 40% of the cases. So that's retrograde approach is a very essential procedure in current CTO PCI. And so that is so retrograde approach improves success rate in complex CTO. Because this is depend on the JCT score, so the score high is also very difficult cases. So JCT score 4 or score 5, so about 40% of the cases are retrograde attempt. And so this is another data. So this is also JCT score more than 3. We need also retrograde approach. So this is the history of the retrograde CTO PCI. At first, retrograde wire crossing is initial technique, and after that, kissing wire technique, and after that, we use a cut technique. So this is we have to advance balloon from the retrograde. So sometimes it is risky for the channel injury. So that recent technique is almost reverse cut technique. So this is a recent data about contemporary retrograde PCI. About 60% or 70% of the retrograde approach is done reverse cut technique. And so the right of the retrograde approach, high success rate, especially in complex CTO, whereas the antegrade approach is not technically feasible or fails. And the more promising and efficient recanalization is CTO with a poor quality distal vessel or significant side branches at the distal curve, and a lower contrast consumption in patients with CKD. And so we have to discuss about when to go retrograde. So this is from the registry data. This is Japanese retrograde summit data or expert registry data. About primary retrograde approach is about 30% of the cases. And retrograde, primary antegrade is 70%. And so if failed as an antegrade approach, 23% of the cases are changed to the rescue retrograde approach. And so when we have to concern about the retrograde approach, this is a global chronic CTO algorithm. And so at first, the most important issue is dual injection and careful analysis of angiogram. And so when we cannot see the proximal cap ambiguity, so that is the same as Dr. Hamasaki's case. So if there is a presence of the side branch, we have to check the IVAS. And if there is we cannot see the entry of the CTO, at that time, retrograde approach is one option. And also poor distal vessel quality, so that is the same as BK Sensei's case, retrograde distal vessel quality. At that time, if there is retrograde options, feasible retrograde options. And final is antegrade wiring was failed. At that time, retrograde approach should be done. And proximal cap ambiguity with side branch, that's IVAS guide puncture should be done. And without side branch, one option is move the cap. That Robert Senses mentioned that. And retrograde approach is one option. And at that time, we check the feasibility of the retrograde occlusion and channel, or distal exit, and distal to lumen, the angle. So the for the channel evaluation is so of course so vessel size is important at first. After that so reverse bend and continuous bend and corkscrew. That is so not all the cases we have to evaluate, but sometimes this point is important. Especially so the vessel size is so non-septal epicardial channel is very important. And so the angle of the retrograde channel to the so distal end of CTO, and so the angle and so distance from the so channel to the distal CTO exit. That is also important. So we have to care that. So this is a case of the so LAG CTO. So this is a bifurcation, and so entry is also not clear. So at first, so inserted so diagonal branch, and so after that, so retrograde approach, and we cannot see the so entry. After that, so Gaia next one was closed, and direct retrograde wire cross we succeeded. So retrograde approach is useful when the proximal cap ambiguity. And so this is a vessel distal vessel quality. And so this is a proximal RCA CTO, and this is a left coronary artery. And but so unfortunately we cannot see the so distal CTO exit clearly. So this is another view. So very long CTO, and so we cannot see the so distal exit, so we cannot see. So this is a CT, so proximal site, and so distal site. This is a double CTO, and so that so distal vessel quality is unknown, and so we have to check the so retrograde, and so the patient is also EF is 70%. We use Impera, and so retrograde approach was easily succeeded in this situation, and implanted the stent. Like that, so retrograde approach is also useful when the distal exit ambiguities. And so final so failure of the so antegrade penetration, and this is already CTO. Like this one. So at first, so XDA and Gaia next one and was failed, and so parallel wire technique was also failed. So distal vessel was disappeared. And so I was inserted so almost so the guide wire is a subintimal space, so that we changed it to the so retrograde approach. And fortunately, so this RP branch was so 03 was succeeded cross, and the reverse cut technique was succeeded. So how long can we continue guide wire manipulation in the so antegrade approach? So this is so data from the so expert registry. So about so they recommended 20 minutes guide wire manipulation, because so almost so median success crossing time of the antegrade single wire was so 73 minutes. And so this is another data of the so how long can we manipulation antegrade? If that's so 60 minutes, more than 60 minutes, it is so very associated with so wire perforation. So that so we have to mention that. So this is the last slide. So when to go retrograde, so when proximal cap ambiguity or so poor distal vessel quality, and antegrade wiring. If and antegrade wiring is so within 20 minutes. If so, we use so 20 minutes. At that time, we have to care about switch to retrograde or so ADR or parallel wire or IVAS guide rewiring. Thank you for your attention.
Thank you. So we move to the Severance Hospital. Ige, we are back.
Yeah.
Yes.
Okay.
So-
So the could you show the angiogram? Okay. So the this is O0 3.0 40 millimeter, right? Yeah. Right. And also the under the ankle ballooning is a wire cross stent crossing is very easy. And next one. And then the on the I was finding is proximal RCA ostium is also a very big disease. So I want to cover of the RCA OS2 middle portion. Next one. So a little bit removed. Next one, and then the inflation. Next, and then a little bit removed, and then I increase the pressure with high pressure. And next one, and could you show this angiogram?
Yes.
Yeah, this is the angiogram. So maybe the one more IVUS exam was needed, but a little bit enlarged of the proximal portion is the distal vessel is also expansion was a little bit. So based on the IVUS findings, I will decide to perform the DCB of distal region or not.
So, any opinion? Or DCB to the DISA? Or leave it or DCB?
DCB is better.
I would stent it. I think.
You
I know.
want to put stent?
I think I would. Yeah. I mean, this. DCB will just give a few months. I think. This patient really needs. You've done a great job. I would just put a stent in. And if there's restenosis, then DCB. But that's my own preference. There's lots of disease, very diffuse, long area of. It's very on the IVUS. You can see it's very fibrocalcific, so the plaque's not very soft, and you need the radial strength, I think, of the stents. If it was more fibrofatty, then I would go more with maybe DCB.
Okay. So there is some small dissection. These are part of the stent.
I should check. Yeah, so, but and also in our data of the serial IVUS follow after successful CTO, so about 70% patient show the distal vessel expansion comparing the two IVUS exam. So especially the RCA and also the proximal region is definitely related with the vessel expansion. So if I put the stent in this angiogram, maybe the 2.5 would be the maximal stent size. But the reason why I should do the DB or not is not stenting. There is some kind of reason.
It's sometimes difficult to decide the stent size.
Right.
Yeah. Because sometimes the stent is very small.
Right.
It's a cause of the stent failure, long term.
And do you have the Limus DCB in Korea? You have the Limus one?
No. I'm not sure. Do you have a Limus?
What type of DCB is it? Limus or paclitaxel?
Only paclitaxel?
Only paclitaxel. Only paclitaxel.
Okay, well then stent it.
You don't believe the DCB of paclitaxel?
Look, there's a big debate. But look, we know that, this is an extension from the stent literature, that Limus is the superior agent to paclitaxel. So it's a matter of time. The problem with the Limus DCB is it doesn't last very long on the shelf. They have to move them a lot. They go out of date. You can get some nice ones, that are slightly more deliverable. So if it was me and you open my CTO, a choice of a third generation drug-eluting stent with thin strut like a zero with a nice Limus drug versus a balloon with paclitaxel, I know I'd go with a stent. I think that would be for my body.
So I don't know the data of the Limus DCB. So is there the resonance rate is similar?
So
I have some resonance rate is a little bit higher than paclitaxel.
I'm not aware of any randomized head-to-head studies. I think, anecdotally it's difficult. I think most of the work has been done with the paclitaxel agent.
Okay, anyway, you check the IVUS BK?
Okay. Yeah. So and also the previous Otsuji sensei, maybe the previous meetings told us is distal DB is okay. However, some dissected portion of DCB is sometimes related with the aneurysmal formation. Yeah. So especially in CTO, right? So the that comment is also we should remember.
So the severe dissection maybe cause the aneurysm because of paclitaxis accumulated adventitia mostly. So maybe the different cause using the LIMS stent.
And the thing is, in some countries, like I work in Australia now, it's very difficult to bring the patient back for check, surveillance, angio. So I've tried in some of my complex and left main to do surveillance angio, which I normally do like 9 months, and it's been blocked because unless they have symptoms, it will not be paid. So you could have a strategy where you do the DCB and bring them back. If the vessel's bigger, but there's still areas of disease, you then stent, and I think that would probably be the best solution. But in some countries, it's just not possible. And I personally think IVUS-guided DCB is better than non-IVUS-guided as well, so you get the correct balloon ratio.
So maybe some stent part protruded the ostium, maybe.
So actually, because of long procedure time, IVUS catheter was kinked. So I should remove the system. Sorry.
I think enough procedure. Because
so maybe you change the guide or JR.
All right.
It's okay. But sometimes guide wire go beneath the stent.
So, but anyway, please give me the opinion. So if there was no significant dissection in the middle portion, so the DB better or stent better, so what should I do?
Dr. Berger would like to put stent.
Maybe. Why don't we do this for everyone in the room? If you put a stent distally, put your hand up.
I'd like to see.
Okay.
In this point, so we don't see the severe dissection. We don't see the severe dissection, and also mid to distal part of the RCA is relatively large, but we can't put a very small stent. And from the IVUS information, the distal part will enlarge. So at the later phase, so that this time, I don't like to put stent around. Just DCB is better.
I agree with because. Even though
maybe we get be careful of ostium.
Okay. Right.
Even though IVUS showed a minor dissection or trivial dissection, so leave it alone because DB is enough to because long procedure time and long contrast is more harmful to patients.
Check angio again.
Enough procedure.
Okay. So I think this IVUS evaluation is also sometimes not so good. Is already I put the pressure is up to 24 atmosphere on the stent balloon. Angio. Okay. Okay. I think, in my opinion, so is the Hashihara sensei mentioned is on the angiogram was not so severe dissect, right? So the just observation and short-term angiographic follow is also kind of way.
Yeah, maybe it's expanded after the follow-up. So okay. It's time to close. So sorry, we have to leave now. Thank you very much.
Congratulations.
Good procedure.
Thank you.